Good morning, everybody. Today we are going to discuss about something very important, very exciting thing for all those people who are working in ICU. You might have realized or you might have participated in a resuscitation of a patient. When somebody lands up in a cardiac arrest, there is complete chaos and the crisis boils down to who is doing what, everybody running around here and there. Now, many times we feel that what best we can do in such scenarios and how we can be in control, how we can do the best possible thing so that the patient recovers. What can be best done in the interest of the overall situation? Today we are going to break this down in next 5 minutes how to do things correctly. And for this, we'll follow ACLS protocol for cardiac arrest. So I'll straight away jump to this protocol and what it is and what does it say. So here we go. This is cardiac arrest algorithm. And what does this algorithm say? That if you see that somebody lands up into a cardiac arrest. Now, what is in cardiac arrest? Patient is unresponsive, he is not breathing, and there is no pulse. If these three criteria are met, then we say the patient has landed up in a cardiorespiratory arrest. The next thing we should do is start CPR. Anybody who's trained in CPR should start the CPR because this is the single most intervention which decides the survival of the patient. If this is delayed or if this is a low quality CPR, the chances of survival of your patients are low. So start in good quality or high quality CPR. Once the CPR is initiated, now how many people are required for management of an cardiac arrest? Ideally, 5 to 6 people are required. I'll break down one by one. One person to give chest compressions, other to take care of the airway, third person to manage the defibrillator, fourth person to administer drugs or give injections, fifth person as a team leader to see overall, analyze, assess, go back and see where we are making mistake or what needs to be done. And then the last person to take down the notes. So at least 5 to 6 people are required to manage a cardiac arrest effectively. Now, what happens is if the roles are divided beforehand and if everybody knows who is going to do what, then things become very clear. Say, for example, there are 6 people in your ICU and bed number 6 patient has landed up in cardiac arrest. You all 6 people go over there. One person starts chest compression. That is the first and foremost thing. And then what do rest of the people do now? That we'll see one by one. Now, the next mantra which should come to your mind is IV O2 monitor, IV O2 monitor, IV O2 monitor. I'm repeating this once again, IV O2 monitor. Why? Somebody has to take an IV access immediately, start oxygen, attach cardiac monitor leads or the defibrillator, whatever you have, attach the leads and see the rhythm. Now, once you have done this, given oxygen, attached monitor and defibrillator, and then you check the rhythm. If this rhythm is shockable, then deliver shock. You already have connected the cardiac monitor leads or defibrillator leads. If it says or if it shows that the rhythm is shockable, then you deliver the shock. Now, what is a shockable rhythm? Either a VF or a pulseless ventricular tachycardia, VF or a pulseless VT. This is what they mention over here, VF or a pulseless VT over here. And then you deliver shock. How much shock is to be delivered? Depending upon what type of defibrillator you have. If it is a biphasic, then you give 200 joules. If it is monophasic, you give 360 joules or whatever maximum is available in your defibrillator. And then once the shock is delivered, you immediately resume the CPR. You continue the CPR. You keep on continuing the CPR. Monitor the CPR quality. And you keep on giving the CPR. Again, after 2 minutes, you check the rhythm. If it is shockable, deliver the shock and keep on giving this CPR. So CPR is the key. CPR is the key. Now, what happens is every 2 minutes when you do CPR, and if the second time if the rhythm is not shockable, you continue the CPR. What else you can do? You can give drugs. Adrenaline every 3 to 5 minutes, or epinephrine every 3 to 5 minutes. Continue the CPR. Even after, then again after 2 minutes, you assess the rhythm, check if it is shockable or not. If it is not shockable, then next line of drug what you can try is amiodarone or lidocaine for refractory ventricular fibrillation or an pulseless VT. We'll see what is the dose of amiodarone, lidocaine, and adrenaline. And then you consider advanced airway, that is endotracheal intubation. And in some centers, they do this quantitative waveform capnography. Even if you don't have this facility, ensure that the tube is in the place and patient is ventilated properly. And then you look for all the reversible causes. I'll go one by one. What are these reversible causes? Now, here we see what is the quality of the CPR. This is the most important thing, because if this is not taken care of, then uh, the chances of survival are less. Now you have to push hard and fast. Now, how deep you need to push? There has to be a firm surface on which the patient is lying. If the surface is not firm, if it is an air bed or some cushion bed, then you have that file, a firm file in on your crash cart. Remove it, place it behind the patient, and start giving CPR. So the compression has to be adequate, the depth has to be adequate, at least 2 inches or 5 centimeter, and give it hard and fast. Fast means at least 100 to 120 compressions per minute, and allow complete chest recall. This is very important, because if you keep on pushing and if you don't give opportunity for this complete chest recoil, the lungs are not going to get inflated completely. The most important thing is to avoid interruptions in compressions. Like if the person who is giving CPR is tired and there is switch roles between two people, then you have to ensure there is minimum interruption. And the person who's giving the taking care of the airway, if he's switching role with the guy who's giving the compressions, then you have to ensure that there is minimum interruptions in the compressions, and also the person who's giving taking care of the airway should not land up with excessive ventilation. Every 2 minutes, change the roles, otherwise you will get fatigued, and give at the rate of 30 is to 2, 30 compressions to 2 breaths, and ensure the quality of the CPR is good. Even if you don't have this facility of quantitative waveform capnography, it is fine as long as you give good quality CPR. Now, how to deliver the shock? As I said, if it is a biphasic, initial dose will be 120 to 200 joules, and the second and subsequent doses can be equivalent or higher depending upon the condition. If it is monophasic, 360 joules. When you give the shock, ensure that you apply jelly, ask the people to stay away, count, see that I'm going to shock the patient at the count of three. 1, 2, 3. We all are clear. I am clear. You are clear. Everybody is clear. And then deliver the shock. Now, what are the drugs to be given? Adrenaline 1 milligram every 3 to 5 minutes. Amiodarone first dose 300 bolus, and then 150 milligram. And if you're trying to give lidocaine, then if the person is 60 kgs, somewhere between 60 to 75 milligram first dose, and 30 to 45 milligram second dose. That is how we give this lidocaine. And then when we plan for this endotracheal intubation, ensure you do rapid intubation, avoid delays into this, ensure the tip placement is correct, and confirm it, and ensure the patient is ventilated properly. Once the patient is on endotracheal intubation, then you can give one breath every 6 seconds. Now, when the patient returns to spontaneous circulation, that is return of spontaneous circulation, checks the pulse, the blood pressure, you can stop the CPR over here, and you'll see that there are some changes on the intra-arterial monitoring if you have in place. If you don't have in place, that's fine. But check the pulse and the blood pressure and do the next step. That is the care, post-resuscitation care. Now, many a times the patient doesn't improve, and then we step back and think, what is the cause? So here, 5H and 5Ts. So look for these causes. If there are any of these causes, try to correct them. Hypoxia, is the patient being ventilated properly? Are you delivering enough oxygen to the patient? Is the patient hypovolemic? Give IV fluids. Take sample for ABG and see if there is acidosis, hydrogen ion or H ion acidosis. Take the blood sample, send for electrolytes, sodium, potassium, calcium, magnesium, and check if there is any of these electrolytes are abnormal, like hypo or hyperkalemia, and lastly hypothermia. So these are the 5H we will take care of, and then the 5Ts, whether the patient is having coronary thrombosis, or if the patient has pulmonary embolism or pulmonary thromboembolism, or the patient has a cardiac tamponade, or patient has landed up into a tension pneumothorax, or patient had presented to you with a severe trauma, or he has some toxins which need to be dealt immediately. So these five T's and five H are very important when you manage this patient of cardiac arrest. Now, to sum up, everybody knows their role. What are we going to do? Everybody knows what is the next step. And if somebody freezes during cardiac resuscitation, the other people help him, the other people prompt him. The person who is giving medication needs to repeat loudly when the person gives the medicines. Okay, 1 milligram of adrenaline given, or I'm going to give adrenaline 1 milligram, and then you give that. So everybody knows what is happening around. The team leader who looks at the monitor and sees, he doesn't get involved himself, he looks from far what is going on and what mistakes we are doing. He should notice if the quality of the CPR is not good, he should notice if the medications given are correct, he should analyze the rhythm, take a decision, we are going to shock this patient or not. The person looking after the airway should ensure that the tube is in place and the patient is being ventilated. So this is how we do resuscitation or take care of a cardiac arrest patient as a team. This is in teamwork, because unless and until all the rules are clear, you're not going to be a good team. And if the team is not good, the chances of survival or the outcomes will not be good. And every time you can change the team leader. So today, if you are taking care of the compressions, tomorrow you can be a team leader. Next day, you can be the person who is taking care of medications. This is how you can switch roles. I hope this was amply clear to you all, and best wishes in all the resuscitation programs which you participate. Thank you so much.